Welcome, everybody. We're very fortunate today to have Dr. David Martin with us. My name is Professor Peter Nash from the Griffith University in beautiful downtown Brisbane in Australia. And David is the Executive Medical Director at Pfizer. And he's going to discuss with us today a paper that I've been very interested in and very keen to discuss with him. It's about biomarkers to predict risk of venous thromboembolism in patients with rheumatoid arthritis receiving tofacitinib or tumour necrosis factors. And it was published in RMD Open, and it was published in July of last year, but it's the only paper I've ever seen which has tried to examine all the usual thrombogenic things that we think about when we have patients with VTE, because I'm desperate to understand, is the issue with JAKs a class effect or a JAK2 inhibition effect? And up until this paper, I had never seen anyone look at the normal things you and I look at every day: antithrombin 3, factor 5 laden, protein C, protein S, etc., etc. So welcome, David, and thank you very much for giving us the opportunity to discuss this important paper with you.
Thanks, Peter. It's great to talk to you, and thanks for making the time. I'm happy to spend the next few minutes to chat about this paper, which really was quite an effort, quite a team effort for us to try to make sense of the data coming out of the oral surveillance. And I know that you've talked about that large study on this podcast before.
All right, so tell us a little bit about yourself, what you're doing, what your interests are, how this particular paper came about, and then we'll set it up and talk about the paper itself.
Yeah, sure. So I'm a physician and rheumatologist by training. Spent years doing basic immunology research, first at the NIH, and then after fellowship in San Francisco, moved to Seattle, was at the University of Washington for a number of years, had a small lab, and then moved into industry in 2007. And since then, so really more than 15 years, I've been involved in bringing medicines to patients, including both small and large molecules, mostly working in the early development space, so phase 1 and phase 2 in inflammatory diseases, so rheumatic disease, the derm, and GI. And I transitioned to Boston about 8 years ago, and for the last 7 years or so, I've been at Pfizer here in Cambridge, working on inflammation immunology research unit. Much of that effort for the last 7 years has been focused on the Janus kinase of the JAK franchise, and so yeah, I'm happy to talk more about that, but it's exciting times.
It is exciting times, but it's fair to say that oral surveillance, where one drug in one disease, and the FDA made this broad sweeping class black box for every indication, for every JAK, and it was enriched for cardiovascular risk factors. It was an event-driven trial against the TNFs, adalimumab, I think, in the US, and etanercept overseas. And it's fair to say that it has changed a practice around the world. What's happened to the JAK market in the US as a result of oral surveillance before we get into the paper?
Oh, well, I'll be honest with you, Peter. So I wasn't involved with oral surveillance from the get-go, and I can talk more about it. But as far as the JAK market and how it's been affected, it really is something that I'm not particularly close with, and how it's been affected. I know it's not been a positive effect, and
yes,
there's been a lot of questions raised about it. It's just that, most of my focus, and as I'll tell you, historically, I worked on this from 2019 for a couple of years, but it really has been the center of my focus the past couple of years. But it's certain that these results from oral surveillance have had a significant impact in the way that JAK inhibitors are used in the class.
Sure. And I think that's the key question. Were the findings from oral surveillance a class effect or a JAK2 effect? When you push the dose, you might get more pan-JAK. Do you think that's a fair statement? If you push the tofa dose up towards 10 BD, in some people you get a pan-JAK effect, not a selective JAK effect?
Well, it's interesting that certainly when tofacitinib was first described, CP 650, 69550. It was initially described as a JAK3 inhibitor. You go back to some of the earliest papers in early 2000s. We had a long-standing collaboration with the NIH and Pfizer scientists. And the truth is that what we didn't know was the importance of the way you assess JAK inhibition. And it took a number of years and a great deal of work to really understand that tofacitinib does affect JAK3 and JAK1 to a much greater extent. And then, as you suggested, at higher doses, there is an effect on JAK2. And you can certainly see that for the JAK2 dependent pathways, specifically when you look at hematocrits and platelet counts at these higher doses. But I think your question is spot on, which is to say, is this VT signal? Is it a JAK2 effect, or is this something beyond? Because, as you know, there's many pathways, more than 50 plus pathways that are JAK dependent and depend on JAK pairs. And JAK2 is the only JAK isoform which doesn't depend on either JAK1 or TYK2.
Excellent. So, with oral surveillance, a 10 milligram dose had a signal. They changed the study halfway through and continued the lower dose. So let's talk a little bit about this particular paper. What did you try to do with this study to help us understand the mechanism of action? Because that's what I've been asking for the companies for years since this paper, since oral surveillance. We need a mechanistic understanding of what's going on to help us decide who's at risk, can we predict, is it the class or is it JAK2? So what were you trying to do with this paper?
Yeah. So as you pointed out, the oral surveillance study was a study that was a post-approval safety study that was mandated after tofacitinib was approved in 2012. So the study started in 2014, big study, and the goals and primary endpoints in the oral surveillance were adjudicated Mason and cancers. It was not VTE. It was only after the Data Safety Monitoring Board noted in 2019 that there was an increase in events that the protocol was changed, and the higher dose was rolled into the 5 milligram, 10 milligram dose. Patients were rolled into 5. So in terms of what we were doing, it really, as you said, it was a question about, can we use the samples that are collected to better understand mechanism for this observed increase in VTE. I think that it took a lot of work, but we were hamstrung really from the beginning. And I'll say that just if you read the paper carefully, you'll note that we were able to. We started with a very limited sparse blood collection. And it was a baseline month 12 and month 6. It was a 5-year study. So it was a huge population of over 4,400 patients. And, after the signal came out, we reached out to some experts in VTE and so forth. And the first author of this paper is Jeff Weitz, and owe him a great deal of credit for the way we designed the study. But really, we're looking at sort of, how can we best get at this question? So Jeff had suggestions about looking at sort of common things being common, looking at things like the D-dimer, looking at C-reactive protein. He thought that was the sort of the most likely to yield some useful information, and that's probably what we're going to end up talking about most. But we also did a handful of other more exploratory things, and it's quite a complicated thing because we looked at just so many, including sort of markers that most people might have heard about, things like TPO, but also other things like factor 8 and some of the other clotting factors. And then we did more of an exploratory look. We call them tier 3 and tier 4 by looking at some more proteomic markers using a technology known as Olink. A lot of markers, a lot of data, a lot of patients. And then, of course, we looked at some of the other things that were more well known as far as risk factors, such as genotyping of the factor V Leiden, and then things like the and prothrombin, and then other things that are known to be associated with autoimmune diseases, such as some of the known antiphospholipid antibodies, which are associated with CLOD. So that was. Go ahead.
So you had 62 patients were randomized. You had 285 patients, 57 VTEs, and 228 match controls. And you had a look at a whole series of these things. And did you follow them over time, or was it at one time point that you did the comparison between the VTE patients and the match controls, if you like? And were the match controls inside the study or outside the study?
Yeah, these are good questions. So we looked at the baseline to see if there were specific markers that might predict the patients who were going to go on and develop CLOD. And then we looked at the changes from baseline at month 12 and then again at month 60 to see if any of these nearly 300 markers predicted or showed an association with VTE. And we broke it down then by DVT and PE. So it was in the genotype, we obviously just did once at baseline. So we did look at changes, and that's described in the paper. Much more details have come out with many other papers that describe the oral surveillance study, and there's actually a manuscript that's going to be coming out fairly soon that describes, much like the original manuscript on MACE and malignancies, there's one that's going to be focused specifically on VTE that's going to get into more of the details of the patients themselves. But as far as the markers themselves, we had limitations because if you can imagine, if we got a baseline marker in a month 12, if somebody has an event, say at month 6 or at month 36, the value of a month 12 blood test is limited. We're not going to be able to know years later, months later, how to interpret something that is years away from the event itself. So that was one of the major problems. Normally, when someone comes in, you immediately you can associate the blood test with the symptoms or the signs at the time of their problems. But we couldn't do that. We were limited because that's the way the study was set up. It was not a study specifically set up to look at mechanism for either MACE, malignancy, or VT.
So you looked at plenty of markers that we usually check for when we've got someone with thrombogenic risk. I wondered about markers of endothelial dysfunction and what you feel the JAK-STAT pathway inhibition might affect endothelial function. And so we'll be looking as long as we cover those markers, is it more likely to be endothelial issue or a marker change, if you know what I mean?
Yeah, so unfortunately,
like von Willebrand's factor or something like that, which is a kind of an endothelial dysfunction measure.
Yeah, a lot of these markers, as you suggest, like von Willebrand's factors and some of the other factors that we typically think about for being associated with endothelial, they did not. We tested them. We looked at them carefully with a proteomic platform, but nothing turned up as being associated with either the DVT or the PE. And the short answer is that it was disappointing in that way, even though we looked hard and we spent a lot of energy looking at and developing these assays. Nothing really bore fruit that was statistically notable, as I said, in part because of the way that the study was set up, and as well by the fact that there were actually surprisingly few events, even though roughly 50, but that's they were over time. So we looked at month, I said baseline month 12 and month 60. For patients who had events early, we called them early before month 12. We were limited in making some of the comparisons, say for the month, using the month 12 data, look beyond that.
And if we look at the baseline demographics, of only 1% or so had a history of VTE. Were they the ones who had events? There was 3% on an oral contraceptive. Did that make any difference?
Well,
14% was
yeah,
14%
it's
was
interesting
on
you
aspirin.
point
Was
that out.
aspirin protective?
Yeah, I think that the manuscript that's going to be coming out actually does very clearly point to the history of VTE as being a major risk factor. I mean, this seems obvious that if you've had a prior VTE, you're at increased risk. And in fact, I think that those data confirm that is the case. That history of VTE.
Oral contraceptive?
I don't think oral contraceptives are as striking as the history of VTE, and the other one that really stood out was smoking, and that also came out when the new labels came out, that the history, present or past, of smoking clearly was associated with an increased risk of events.
Okay. Anything else that stood out as either protective, like perhaps aspirin, or a risk factor that we should be aware of?
Well,
mind you, aspirin only protects arterial, not venous, so you wouldn't expect it to make a big difference.
No, I do think that within our study, the short answer is with the biomarker study, the short answer is nothing really stood out. It was, frankly, was a bit disappointing as far as what we did see, and I'm happy to talk more about the D-dimer because I think that's probably the most interesting result. But as far as the things that I think people are going to take away from the entire experience with regards to VTE is it relates to disease activity itself. Right. And so while we were doing this study, there's a Swedish group came out with some really nice work that clearly demonstrated that patients who have active disease are more likely to have clot. And ultimately that I think that's going to sort of be the message here, that if patients still have active disease, you need to be concerned about the possibility of developing a clot. And there's additional work, I think, from the same group that are looking more specifically at different subclasses of medications, including JAK inhibitors, TNFs, IL-6, etc. But I don't think, as far as and one last thing is obesity. BMI really did stand out as seemingly another. But again, this is an obvious, we already know that obesity probably contributes to VT risk.
We'll talk about D-dimer shortly. You did compare the JAK against the TNFs. Was there anything that was helpful from your study from the TNF side or the tofa side? Any differences in that comparison?
Yeah, I mean, it's interesting. Both medications clearly work as far as reducing systemic inflammation as measured by C-reactive protein, CRP. We know that, and that certainly came through when you look at the data as we presented in the paper, that the controls specifically went down, the cases also clearly went down. What was, as we'll get to with the D-dimer, they both also, the controls also for both the tofacitinib and the TNF inhibitors. Again, D-dimer is a marker of it's a poor man's marker of systemic inflammation. At least that's the way I view it. And they both went down. But as far as the differences between tofa and the TNFs, I don't think anything really stood out. If you look carefully through the supplemental data, there was an interesting finding, like there was one of the markers of TNF receptor was clearly affected by a TNF, as you would have expected, but nothing really stood out amongst the 276 exploratory markers that separated the tofacitinib treatments versus the TNF.
So tell us about the D-dimer results, because I always assumed the D-dimer was a marker that goes up when a clot is present. It might be an acute phase, it might go up with inflammation, but I thought the D-dimer tells you there's a clot present, go and find it. So tell us about D-dimer.
Yeah, this was what I was taught. I mean, for me, D-dimers are something you use to when someone shows up to the emergency room with potential for having a clot or a PE. If it's negative, it's good for ruling out patients. But in terms of it being positive, how can we use that information? There's been a lot of work more recently looking at patients in more of an acute setting. So hospitalized in an ICU, can you use the value to guide treatment decisions around use of anticoagulation, etc. What we discovered in this is that, so first of all, if you look at I think it's table 3 in the paper, that across all the controls, it's a coin flip. Half the patients have at baseline D-dimer levels that are greater than 2 times the upper limits of normal, which to me isn't so surprising. It's like I said, it's a marker of inflammation. These patients were active to come in. And if you look at the cases compared to that, the numbers were slightly elevated. So it was roughly 2/3 of the cases across all the treatment groups. And then over time, if you look at the D-dimer, those numbers go down. So in other words, the number of patients who have a greater than 2 times the upper limits of normal dropped from 50% to like 25 or 30% in the controls. Now, in the cases, and this is, again, probably the most interesting result, but it's actually, in my mind, not that interesting in that we had few cases. They didn't seem to drop by the same token. So, for example, in the high dose group, there were, I think, roughly half were still, or even more than half, so 11 out of 19. I don't like using percentages for such small numbers. Were still elevated, greater than 2 times the upper limit normal. And in the low dose group, I think all of the cases, but there were only 6. So that's part of the problem, is that there were so few cases by the time we get to month 12. And we excluded cases for when patients were anticoagulated, where we didn't include them for the measurements of the D-dimer. So that was one of the problems, is that over time, as these cases dropped out, we had fewer and smaller numbers to be able to look at. But I think that, raises the question, can we use the D-dimer as we're thinking about following patients with putting patients on a JAK inhibitor? I certainly hope that people don't come away from this paper and think, I should check a D-dimer on my patients if they're not responding. The problem is that D-dimers go up under many different circumstances, including, obviously, rheumatoid arthritis. So I would.
That's a very important point, that people should not think measuring a D-dimer will be diagnostically helpful, because it's an acute phase reactor that goes up like CRP does.
That's right, and as we learned in back in medical school, that you really need to spend time talking to the patient, examining the patients. That if they're telling you that they're still having pain and swelling, that's important. And measuring their tender and swollen joints is important, so that if they're not yet in remission, and we obviously want to treat the target, they're still active, then that should tell you about continuing to be aggressive with the treatments.
Yeah, it'd be lovely to know if there's a level of disease activity that drives risk much higher than any possible JAK risk, but I'm not sure that's possible to be done. But that table 2 is very helpful. So CRP didn't associate with VT events in either arm. The D-dimer went up and down. Tell us a little about the TPO, because apparently there was a greater risk of subsequent VTE.
Yeah, TPO is an interesting one, and platelets themselves. So I know that the VTE story that many of us have heard over the last 5 years, as relates to JAKs, really came about as baricitinib went to this advisory committee. I think it was 2018, and the FDA was particularly concerned because there were a number of cases of VTE in that program's development, particularly at the higher dose. And at the time, the FDA was very much focused on a mechanism that tied to JAK2 and platelets, which, of course, JAK2 is signaling downstream from TPO. And so we looked carefully. Let me just, before I answer your question, the TPO story. So we look carefully at platelets, and the platelet counts actually. If we go back and you look at the baricitinib, yes, there was a small bump in patients, particularly at the higher dose, but they really weren't platelet counts that you'd think, this puts you at higher risk for developing clots. So as far as I'm concerned, even though the FDA had raised concerns, they didn't approve the 4 milligram dose. I think the story around mechanism for JAK2 and platelets was really not answered. Not to my
I'm with you, because the rise in platelets was so minor.
Yeah.
We're used to those patients with myeloproliferative diseases. they don't start getting serious issues till the platelet count's way up.
That's
600, 800, a million. These patients never went, you start off high when you got active RA. And it really didn't go into the stratosphere to explain any change. So I agree entirely. So TPO is interesting. I'm not sure how a platelet count would explain risk, like you were saying. But if we go down the tier twos, factor VIII didn't seem to have anything. Protein C didn't. You got some proteomic assays. You found a couple of markers. One is a TNF marker. The other is ANG, which I don't know anything about. What's ANG?
Yeah, I think it's angio. I want to say angiogenin. It was when we looked carefully at some of these rarer biomarkers. Again, really quite exploratory. The changes that we saw didn't. Number one, they were either not dose dependent, or they weren't consistent with the changes that we saw as far as the VTE, and the story around Angin just didn't hold together, even though it met statistical criteria. And to be frank, the statistical criteria for such a complicated a setup was quite. It really depended heavily on the statisticians involved in this study.
Yeah, understand.
This
if you do enough comparisons, you'll find one that's elevated.
I think that's exactly right. When you go by the time you get down to these rare markers, it really does become a bit of a fishing expedition. I think that something smelled about right with the D-dimer, and there might be something there with the D-dimer, but it's just not something that's good medicine to be.
It's not straightforward anyway.
Yeah. But as far as I don't know if I answered the TPO question. The TPO question was also one that's interesting because there are anti-inflammatory effects that TPO can be modulated under. It can go up and down in the ways that other acute phase reactions can go. And so I'm not convinced the TPO finding is relevant, but nonetheless, people want to associate it because of the platelets and the story around JAK2. But
the platelets didn't make sense to me. Yeah. And factor V Leiden wasn't helpful. Prothrombin wasn't helpful. JAK2 mutations weren't helpful. Anticardiolipin wasn't helpful.
Yeah,
beta-glycoprotein wasn't helpful.
Yeah, those were pretty rare. We went down and we looked really quite hard. So with regard to the factor V Leiden and the prothrombin mutations, we did see an increased incidence of VTE for carriers compared to non-carriers, but the risk did not vary significantly across the treatment arms. And if you took these patients out, the findings for the higher dose tofa were still present. So it really didn't explain everything. It clearly is relevant. If someone comes in with a clot, you can measure it like you do in anime, but that really is not an explanation. With regards to the autoantibodies we looked, they were quite rare and really quite uninformative. I don't think they're of much value when you're looking at a patient with, say, rheumatoid arthritis, be looking for it. But we looked, and it was a lot of work, rare events to see some of these changes, and they were consistent across all the groups, not really seen with, for example, with the higher dose of tofacitinib, which is where we saw.
And to be fair, the 5 milligram BD dose, correct me if I'm wrong, there was no statistically significant difference. It was a numerical difference.
Yeah, the 5 milligram dose definitely was less. There were fewer events in the 5 milligram dose, and the hazard ratio. So I think they didn't separate in the same way. This is, again, as I said, will be coming out in much greater detail with regards to the overall study, where they really get into slicing and dicing the different demographic and baseline disease characteristics to try to tie together a more clinically relevant.
And even the event rate was not as high as people have seen in various registries. There was just this subtle difference between the two arms.
Yeah, I think you're raising an important point with regards to what people have previously seen. We did a fairly extensive analysis at Pfizer. I think the paper came out in 2020. Philip Meese was the first author, where we looked at the VT risk across
all your diseases,
all the programs, rheumatoid, the PSA program,
PSA,
program, which ultimately didn't get taken all the way to approval, and didn't see much. Then they also did much more extensive breakdowns of looking at and trying to enrich into a population. So that this oral surveillance study, as you know, was enriched in patients who were at higher risk for cardiovascular events. They had to be over 50 and have at least one risk factor. So they did that by breaking down all of the prior data across the programs, and did not see, even though there might have been an increased overall number, there wasn't a statistical separation. So I think that it's an interesting thought, and I think there's more to come here with regards to exactly what is going on mechanistically. But the prior evidence from our internal program, and as well as these other real-world databases, did not show any clear evidence of an increased risk with tofacitinib or to JAK inhibitors, as far as I could understand, as far as increasing the risk for VT with DVT.
I may have missed it, but I've never seen the etanercept data. Is it the same as the adalimumab data?
You mean comparing within oral surveillance etanercept versus
adalimumab?
I'll be honest with you, I don't know those data. What I do recall, and I'm sorry I'm sort of jumping around here, but the rates of VTE, when we first got wind of the signal, we spent a lot of time pouring through our own data, but also at the same time there was another similar study which came out for tocilizumab, the INTRACT study, similar overall design, post-approval study,
at higher rates than in this study with that trial.
That's exactly right. So the rates were different for TNF inhibitors, or very low. I think they were very low for the IL-6, if I recall correctly, that the number of PEs was striking. But again, differences between TNFs between the two studies were not the same. And it just sort of goes to show that sometimes big studies give just, disparate answers.
So there's a very nice conclusion in your paper that you analysed 291 protein biomarkers and 3 genetic markers, and you couldn't identify a clear mechanistic explanation for any difference in rates. The D-dimer was associated with risk but goes up with inflammation and should not be used as a marker to follow over time. And after exhaustive attempts, we still don't understand the mechanism. What about in your mind? Is it a JAK2 effect or is it a class effect?
Boy, so I'll tell you, I honestly don't know. I know we know that JAK2 tied to platelets, and I thought you were going to ask me what other additional research might be interesting. I think understanding the role.
That's the next question. That's the next question, David. Where are you going next?
I'll jump to that one and then come back to your first question. Try to dance around your answer because or maybe I will answer. But to understanding the role of JAK2 and platelets specifically, to me, is a big black box. I don't think we really understand it. And JAK2 also is broadly expressed across other different cells. But I don't think we fully appreciate JAK biology. I think there's a lot more to be discovered. As I mentioned earlier, there was more than 50 different pathways. They're expressed throughout the body, and I think there's a lot more research to come. In terms of JAK2 versus the other JAKs, I mean, we know JAK1 is very broadly expressed and has quite a big impact. I think it'd be very hard for me to say, I think this is a JAK1-driven effect, but we just don't know mechanistically what's driving this. And JAK2, as I said, the FDA certainly believed it was the major mechanism behind the platelet changes, and I believe that, but is it the major driver behind the clots? If I were a betting man, I'd probably say JAK2, but do I feel confident about that? No. So short answer is I don't know.
So we're waiting for the RA Bridge and Branch studies to come out on baricitinib. We can look at the Salinas paper published in Rheumatology and Therapy 2022, and it showed that the risk 1.51 statistically significantly elevated for Barry versus the TNFs, but it meant that if every 1,000 patients treated with Barry instead of a TNF, you get 3 extra VTEs a year. So even though the risk is elevated, it's not wildly increased, but we will look for the branch and bridge. So what future research do you plan? I'm looking forward to that paper that you're talking about, and any take-home messages for the clinician.
Yeah, so to be honest with you, Peter, we don't currently have much ongoing active research to address mechanistically some of these questions. We have a number of external academic collaborations where we're keen to see some of the results, but internally we're not doing a whole lot to further address this question. As I mentioned, I definitely would like to hear more with regards to the role of JAK signaling platelets and perhaps in endothelium. And I think there's definitely more to come with regards to this story as far as VTE. It's exciting times, and I think there's reasons to be excited. I think you point out impressively that the risk is statistically there, but it's still relatively small. And so in terms of the advice to clinicians, to sort of go back to some of the things I said earlier, which is look at the patient, talk to the patient. I would not jump to do more tests to get a D-dimer, as I've already said. I don't think that's of much value. I think that the new labeling sort of provides some guidance as to the sorts of patients you need to be a little bit more focused on. If they're over the age of 65, they told you they got a pack of cigarettes in their chest pocket, and if they've got a high BMI, that's something for you to think about when you're making an individual decision about whether to continue or start a patient on a JAK inhibitor. I think it's going to be a continued debate. Is this a class effect? Is this JAK2? And I think there's more to come to the story.
So I think it's vitally important that you tried to help us understand the mechanism of action with this study. I congratulate you for doing it. This is the first one I've seen that's even attempted to give us a mechanistic approach, because rheumatologists assess benefit and risk on a daily basis with people with every comorbidity that would never get them into a trial. Malignancy last year, infection, infected prostheses, everything you can imagine we have to cope with daily. And we do weigh up risk and benefit and make appropriate choice for our patients. But we love to understand the mechanistic background if we can. That's why the study is so important. And I congratulate you for doing it, because it was just not available, any of the data. And I couldn't understand why people weren't interested in trying to understand and help us with prediction factors, who to avoid and who to give it to. So I think it's important. We look forward for RA branch and RA bridge, and we look forward to thinking a little bit more about platelets and TPO and our risk factors in our patients, which seem to be age, weight, smoking, and a history of VTE. So I thank you very much for your time, David. We greatly appreciate it, and thanks for talking to us. Now, if you'd like to know more about this paper, please read it for yourself, because it's very clear and very concise and nicely written. It's uploaded to the CSF website. You can get detailed slide sets available in the publications section at cytokinesignaling.com. Please subscribe to this podcast on iTunes or other podcast media that you do use, and let us know with some feedback what you think. So thank you so much, David. We appreciate your time.
My pleasure. Thanks, Peter. I look forward to seeing you in San Diego.
Yep. See you in San Diego. All the best.
You too.